at the University of Colorado Hospital, Anschutz, and the Center for Bioethics and Humanities on the Anschutz campus. I'm Jackie Glover. I'm a philosopher ethicist. I co-direct the Ethics Consult Service at the University of Colorado Anschutz, and I serve on the Ethics Consult Service at Children's Hospital. I'm a professor of pediatrics and at the Center for Bioethics and Humanities. And I'm very pleased with our topic for Ethics Grand Rounds today. And I'll introduce our speakers. Three announcements. First, please put your questions, comments in the chat. They have assured me that they'll leave time for questions at the end. Second, coming up on June 8th is our last Ethics Grand Round of the season called Red Flag Laws and the Colorado Clinician from Dr. Chris Kneppe, assistant professor in the Department of Medicine. And I just want to remind you of the CHEF conference coming up Wednesday, Thursday, May 24th and 25th. CHEF stands for Colorado Healthcare Ethics Forum, and it's called Healthcare Professional Moral Distress, Burnout, and Solutions. So I'll say that again at the end. But our topic for today is a very interesting one: ethical considerations for returning clinical genomic results from a population biobank. We have with us Dr. Christina Aquilante, professor in the CU Skaggs School of Pharmacy and director of the Pharmacogenomics Clinical Integration Program. I thought I would butcher that. Sorry, Chris. And Dr. Coughlin, associate professor of pediatrics and at the Center for Bioethics and Humanities. Dr. Coughlin is an ethical, legal, and social implications, an LC genomics researcher. And Ms. Emily Todd, certified genetic counselor, instructor in the Department of Biomedical Informatics at the Colorado Center for Personalized Medicine. So thank you all for joining us, and I'll turn it over to our distinguished panel.
Wonderful. Thank you so much, Jackie. Can you see the slides okay? Yes? Okay. Thank you so much. Hi, everyone. I'm Chris Aquilante, and today Curtis, Emily, and I are going to be talking with you all about ethical considerations for returning clinical genomic results from a population biobank. Also on the Zoom, we have Christy Crooks, who is the director of the Biobank PI, and Elise Shalowitz, who's a patient engagement specialist with the Biobank. So they'll be available during the Q&A period as well. It was about 5 years ago that Marilyn Kors and I spoke with this group about what was going on with the Biobank on campus. So it's really exciting to be back after 5 years to kind of talk about where we're at and kind of what has happened in that time period. So let me see if I can get these to work. So today we're going to talk about the key features of the Colorado Center for Personalized Medicine, or CCPM Biobank. We're going to identify and analyze ethical issues associated with return of high-impact pathogenic variants and clinical pharmacogenomic results from a population biobank, and discuss approaches to maximize participant benefit and autonomy in a biobank model. So just to give you a big picture overview by the numbers, our biobank on our campus with CCPM, it's the 4th largest academic biobank in the nation and the 6th largest biobank in the nation. Right now, the latest numbers, we have greater than 220,000 participants consented, greater than 120,000 blood and saliva samples collected. And we're the only biobank in the nation that offers consenting 100% online. I'm going to assume that most are somewhat familiar with the biobank, but for those who aren't, just to give you a very, very brief overview of what kind of the flow is, patients at UC Health can sign up for the Biobank study on their electronic patient portal at UC Health, which is My Health Connection. And they can do it via My Health Connection. They can do it at an e-check-in appointment, for example. If they consent to participate in the research study, at their next regularly scheduled blood draw, a blood sample is collected, and that additional tube of blood is sent to the Biobank lab on campus. That lab is CLIA certified, and in the lab, with the sample, the DNA is extracted, processed, and stored. The genetic data is generated and made available to researchers across the campus. It's kind of married with other health information to help facilitate research and genomic discoveries. Now, we've had a couple of iterations of the Biobank consent form over the years. I'm not going to go into great detail about that, but our current consent form is what we call a unified consent. And so when a participant signs this consent form up here in number 1, what they're consenting to is research and potential clinical return of actionable genomic findings. And that is captured in number 5 here, return of genetic results. And so we return clinical genetic results to Biobank participants if they've assigned the appropriate consent form. So just to give you another big picture overview, and it's going to be really critical for this talk, and you'll kind of see it split out based on the speakers. We're going to be talking about kind of 2 different types of genetic results that are returned for Biobank participants. And it's really important to note that these have very distinct pathways or mechanisms for return. So Emily's going to talk first about high impact pathogenic variants, which we abbreviate HIPV. And you'll see as Emily goes through this, this is a non-automated return of results. It involves a genetic counselor consenting and returning the results to participants, doing it verbally, and then filing results into EPIC, and referrals are offered to relevant providers. I'm going to then talk about pharmacogenomics, and so genetic results that are applicable to how medications work in the body, so drug selection, drug dosing. It's a very different model of return. It's preemptive return, and I'll explain what that means when we get to that portion. It's semi-automated return. No genetic counselor is involved. No pharmacist is involved. The results are filed as discrete variables in the electronic health record. And clinicians are notified of the results at the point of prescribing using automated clinical decision support or CDS tools. And patients receive their results directly via My Health Connection. So really important to make the distinction between those 2 different types of results, and they have 2 very distinct pathways. So with that, I will turn it over to Emily to start with HIPV.
Thanks, Chris. So hello, everyone. I'm Emily Todd. I'm one of the genetic counselors at the CCP Biobank. I'd like to acknowledge that I also work with Lisa Axel and Lisa Koo, 2 other genetic counselors who have been with the Biobank for many years and have done just an exceptional amount of work in the HIPV return of results process. So HIPV, just to flesh that out a little bit, it's the description we use at the Biobank for results, genetic results that indicate an increased risk of disease that warrant return to Biobank participants. And we'll get into a couple examples of what this is here in a moment. The CCP Biobank was created with the intent, not the sole intent, but certainly part of our goal was to return genetic results to Biobank participants. The process was developed based both on outside publications recommendations and internal consensus with individuals on our campus, including ethicists like Curtis, who's going to speak next. So in just an example of a publication, so in 2012, the NIH had a publication from a project group they funded that comprised individuals with many different areas of expertise, so bioethics, law, medicine research, And some of their recommendations included that biobank research systems should offer to return incidental findings and individual research results. Beneficence requires that information potentially of use to participants ought to be passed on to them. And researchers' duties to manage and offer return of incidental findings flow from ethical duties to respect participant autonomy and interests. So to many of us here, this might seem somewhat obvious, but certainly there's not consensus amongst everyone that this is the case. But these recommendations very much align with our goals for our biobank. Next slide, please. So a biobank population is unique. There are some special considerations for providing genetic results to this group of people. I'd like to start with the idea that these results are likely unexpected. These are not individuals who went to a genetics clinic or went to see a genetic counselor asking for a genetic result. And to this point, there was a publication by a biobank similar to ours, the Mass General Brigham Biobank, and they reported that 76.3% of their participants who received a genetic result were previously unaware that they would have been at risk. Over half of those people met published professional criteria for genetic testing, but had not been tested. And the other point we consider is that genetic results impact whole families. This is something that we talk about quite a bit. A number of people want to receive the result, not for them, but for maybe their children and their siblings. And so that is part of the motivation for receipt of results. Thank you. Additionally, it's important to note, and this is not just the biobank, this is genetics in general, that not all genetic variation or mutations are disease-causing. So certainly some genetic variation between people is benign, and we wouldn't be addressing any of that through the biobank. Some genetic variants cause different presentations in different individuals. We refer to this as variable expression. Some genetic variants are disease-causing in some individuals, but not others. This is referred to as penetrance. And what is really of interest to me is that penetrance of most genetic variants in healthy populations is generally unknown. Our current knowledge of penetrance rates, it's impacted by ascertainment bias, which we can't do anything about. All of the publications that we have to date start with someone who is affected and has a genetic variant. They're the point of entry into studying a particular condition or a particular family, and then we go out from there. So finding of a genetic variant does not equal a clinical diagnosis. And so our biobank is not diagnosing individuals when we provide them a result. We're providing them information on a genetic variant, and then hopefully they can take that and receive some guidance from their other providers as to next steps. How do we return results ethically? Again, to this kind of different and unique biobank population. So there are many individuals on our campus and in the community who participated in our biobank's creation of the consent, also consideration of which genetic results to return, consideration of how to return results. Our current consent, so as Chris mentioned, there have been some different versions of our consent, includes multiple points, but some that I'll bring to your attention. First of all, that we're doing genetic research and testing on biobank samples. Secondly, that we, when we have a completed result, that they are placed into the participant's medical record. Importantly, participants may or may not receive a genetic result, and that biobank participation is not equivalent to or a substitution for evaluation with a geneticist, genetic counselor, or healthcare provider. Which results to return? So anyone on this call who works in, wrong slide, Chris, I think maybe, oh no, I apologize, that was the correct slide. So anyone on this call that works in genetics will recognize that there are a number of different types of genetic results. We could be reporting out polygenic risk scores, we could be reporting out carrier status. We've landed on reporting out, in addition to pharmacogenomic results, the high impact pathogenic variants. How did we come to this? So we're currently following the recommendations of the American College of Medical Genetics, ACMG. Their recommendations are meant to be used in the reporting of clinical genetic test results that then would have a secondary finding. And while that's not our process, currently it's our best guidance. Guidance that's been vetted by the genetics community with written principles and framework for the type of results that to return that's consistent with our values in the biobank. And so ACMG recommends that the reported genes and variants are a recognized cause of a genetic phenotype. Again, this might sound obvious, but it is not. The genetics can be quite tricky if you're trying to interpret a specific gene and variant and understand the impact that that might have on someone's health. Secondly, that substantial clinical evidence exists that the reported findings lead to a high likelihood of severe disease, i.e. penetrance is thought to be high. There might not be much value if we report out a number of results that will only impact a small number of people. Thirdly, confirmatory clinical testing exists. Fourth, that clinical utility exists. And then 5, they do recommend focusing on most commonly on monogenetic conditions. So their list of genes and variants that they recommend returning as a secondary finding mainly focus on cancer risk, cardiac risk, with a few other conditions thrown in, with primarily adult onset. Their current list of genes recommends returning results in 78 genes. They just last summer updated their list to get to this 78 gene number. And because we're speaking on ethics today, I wanted to bring out one particular gene of interest that was just added to this list last summer, and that gene is TTR. TTR is associated with a clinical condition, hereditary transthyretin amyloidosis. And it's a condition in the United States that's overrepresented in the African-American population. ACMG, in their report last summer, when they added TTR to their recommended list, they acknowledge that that gene and the associated condition does not meet all of their recommendations, primarily not necessarily having as high a penetrance rate as they would like. But as this is a condition most prevalent in an underrepresented population, we might not have a great understanding of the penetrance. And additionally, they wanted to add this gene in an effort to address and then hopefully decrease health disparities. And so that really spoke to us as a group at the Biobank, and we've really been focusing on returning TTR results to our Biobank population. So let's go through our process a bit. So when our research study, so we start with research, it determines that a Biobank participant has a result that meets the criteria as an HIPV result. We do initially start by confirming that a participant has signed a consent, agreeing to receipt of genetic results. And then a fairly unique component of our Biobank is step 2, that we have, luckily, a clinical laboratory that can confirm the result. A number of other biobanks provide research grade results to participants and then recommend that they get clinical confirmation. And that's just quite tricky. There's a number of reasons that is tricky. So I'm just really pleased that we're able to offer our Biobank participants a clinical grade result. And so when we get to the step then of actually returning a result, the first thing that we do is one of the genetic counselors, we will reach out to the Biobank participants to further consent them. So yes, they have signed consent forms stating that they would like a result, but maybe it was a few years ago. Maybe their circumstances have changed. Maybe their minds have changed. And so we reach out to them by phone and through my health connection, but even through my health connection, then I set up a phone call and we discuss types of results available from the Biobank. There's a number of questions asking if we're doing genetic testing, looking for risks for, say, dementia or Alzheimer's, and we are not. And so, you know, you can imagine people draw pretty clear lines between, are we looking for conditions that have some screening or treatment attached to them, which is our goal, as opposed to just predicting risk. We also discuss protections under the law related to employment and medical insurance. So we discuss laws like GINA and ACA, and lack of protection under these laws for our military members. We discuss implications of genetic test results on the purchase of life insurance and long-term care insurance. We discuss the process. Our biobank, we do not need an additional sample. Our clinical laboratory is able to go back to the initially provided sample to confirm the result. There's no cost incurred to the biobank participant, and we release the results over the phone so that, again, receiving these results has as low a barrier as possible. Then we determine if the participant will accept or decline to receive the results. So even though they've signed a consent at this discussion, they then still have the option to decline to receive a genetic result. And I have found, and I think Lisa and Lisa have too, that these discussions bring to light a lot of ideas for people that just reading the consent doesn't make obvious. And I think we have a good consent. It's just, having someone call you on the phone makes it more real, more engaging. And so some people then will change their minds. And then we talk about next steps. For individuals who decline to receive genetic test results, this does actually require withdrawal from our biobank because as Chris is going to discuss, the PGX results, that is an automated process that we don't technically have a way to continue on with in returning those results, or maybe returning some results and not returning others. And so we have that discussion as well when we talk to people about declining. And for individuals who are clear that they want no genetic results now or in the future, they're withdrawn from the biobank. They can do this themselves through our website. And I also offer to withdraw participants at the time of that discussion if that's what they choose to do, because again, I'm not looking to put any barriers in place for them in that process. Biobank participants who have signed our current consent saying they do want a genetic result, but do not ever respond to us. No, they don't respond to the phone calls or the electronic messaging. They do not receive results, which is to this last point. For our biobank participants with the current consent form, these HIPV results are only given and placed in the chart with the express consent of that biobank participant. And for those who would like a result, again, we provide a clinically confirmed result. We schedule a phone appointment for return of results. So at that consenting phone call, for people who want a result, we schedule a phone appointment a week later to give our laboratory a week to create and provide to us the laboratory report. Participants are encouraged to have a support person with them on the phone call if they like. And then results are provided verbally over the phone. After the participant is informed, the result is then uploaded into Epic, forwarded to the participant, forwarded to their care providers, generally their primary care, but then maybe also care providers that they work with. Referrals can be placed at the participant's request. We always recommend formal genetic counseling. This process is not genetic counseling at all. It's just results reporting. And then there's some additional supports as well. So quite frequently, people are being informed that they have a genetic risk related to a condition that they are not familiar with. Our website has a number of resources, and quite frequently, I'll even just message those directly to the biobank participant so that they have, so it's easily accessible to them. And in addition to information on the condition of interest, we'll send them a family letter, which is just a very generic letter stating, dear family, I had genetic testing, something was found that was relevant to our family. You might want to discuss this with your doctor, that sort of thing. Really just trying to help them, help facilitate sharing of information through families. It can be quite difficult for people to think about how they're going to reach out to that cousin they haven't talked to in a few years to tell them their family's at risk for a genetic condition. And so that's part of our discussion, and we do try to facilitate that. And here's what we've returned so far. So as of the end of April last month, We had 298 results available for return to our biobank participants, and we returned 65% of them, so it was 194 results. You can see they're pretty evenly split between different types of conditions. So conditions conferring a cancer risk was 31%, conditions conferring different types of cardiac risks. So some of the inherited arrhythmias or cardiomyopathies, that was at 20%. Individuals at risk for familial hypercholesterolemia was 21%. And then this other category, and these are mainly the TTR amyloidosis results, that was at 28%. We have about a fourth of our population that didn't respond. And so again, individuals who are just not returning phone calls, not returning messages. We had 8% of individuals withdraw. So spoke with one of us and then elected to withdraw from the biobank. And then, we had a few other outcomes. So a couple individuals were either actively buying life insurance when I called them on the phone, or they were going to pursue that. And so they wanted to hit the pause button. And then this process takes us a little while. And so we'd had 9 individuals who actually received the results in a clinical setting while we were in the course of contacting them. And so, kind of going through our process. And if someone has received the same result in a clinical setting, we don't intend to provide that to them through the biobank. So I have 2 case examples just to give you guys kind of a sense of what we're doing with our biobank participants. And these are real cases, but also not unique. They're pretty informative just to how this works for us in general. So we had a biobank result reported out to a 32-year-old woman. She was told she had a pathogenic variant in BRCA1. She had no personal history of any health issues. And this result was not known previously to her or her family. I will share, sometimes we will call individuals with these results and they'll say, I think my cousin has that. And, then we'll have that sort of discussion. But this individual had no previous knowledge of this. So just for those of you who are not aware, BRCA1 variants are associated with hereditary breast and ovarian cancer syndrome. So associated risks would include female breast cancer. Lifetime risk is over 60%. Lifetime risk for ovarian, fallopian tube, or peritoneal cancer is maybe 40 to 60%. Lifetime risk for male breast cancer is increased to around 1%. Prostate cancer risk is increased. And for some families, pancreatic cancer risk is increased. So there's a number of cancer risks associated with this result. And then additionally, individuals who have a pathogenic variant in BRCA1 are also potentially carriers for an autosomal recessive condition, Fanconi anemia. So depending on their status, but then additionally the status of their partner, they could have a child with a different condition, Fanconi anemia. So for this, I think young woman, I think 32 is young. So she did have a family history of a maternal aunt and maternal grandmother with breast cancer. And for those of you who are interested, I don't know types or age of onset. But when she and I spoke, she had a breast lump that she was considering having evaluated. So that is the one point of her case that did really stand out to me. She was exceedingly anxious then. I would have been as well. And so fortunately, she was able to get breast imaging performed very quickly. That was completely normal. So she actually ended up with a mammogram and an ultrasound. And now for her, she has a consultation pending with a cancer genetics program to have formal genetic counseling, management planning. She's 32. She has a number of years in front of her to think about cancer screening management. She could have potentially some prophylactic surgeries in her future. And then again, she's 32. She also needs to be thinking about a family planning discussion related to the carrier risk for Fanconi anemia. So that's one example. And then, thank you, Chris. And so my last slide here is, again, my favorite. So we also reported out a pathogenic variant in TTR to a 64-year-old woman. So TTR, the TTR gene is associated with hereditary transthyretin amyloidosis. It's a genetic condition. It is well described, but not generally well known. And in the past few years, therapies have been developed and are available specific to amyloidosis, making the diagnosis of this condition much more relevant than it had ever been in the past. And then again, the most common specific DNA change in TTR noted in the United States is predominantly seen in individuals who identify as African or African American. Hereditary transthyretin amyloidosis is a multi-system condition, and the symptoms include cardiomyopathy, cardiac arrhythmias, neuropathies, carpal tunnel syndrome, renal failure, some autonomic nervous system symptoms. So these are symptoms that are not unique to amyloidosis, frequently associated with other diagnoses. So, you can imagine that the opportunity to be diagnosed with this is, this is a frequently missed condition. And the individual that we're speaking of here, she had some symptoms. She had neuropathy and she had carpal tunnel syndrome, but amyloidosis had never been considered for her as a diagnosis. So when her result was reported, she stands out in my mind because she had a really great relationship with her primary care provider. Normally, when we reach out to primary care providers, just some people have a closer relationship than others. I don't always get a response back from the primary care provider saying like, oh, I absolutely know this patient, I'll take care of them right away. And she had a really good experience with that. So her primary care provider ordered what's called a PYP study, which looks for amyloid deposits, and her result came back strongly suggestive of amyloidosis. She was then referred to one of our amyloidosis specialists in cardiology. Shout out to Amrut Amberdecker. And based off of her symptoms and her study, they have elected to pursue medical therapy for amyloidosis for this patient. So we're really fortunate on our campus. One of the reasons we've been able to provide so many TTR-related results is that we have specialists in cardiology, with specialists in neurology. So we have really good providers we can refer these patients to, or that the primary care providers can partner with to try to sort out if individuals are affected, if therapies are warranted. So now this woman has a diagnosis and a therapy for a condition that had not been considered for her before. And additionally, her family now has this knowledge. And if they happen to be symptomatic, they can then go and discuss this with their providers. And with that, I will turn it over to Chris.
All right. Well, I'm going to switch gears a little bit from HIPV to pharmacogenomics. And so here we're going to be talking about how genetics can affect variability in drug pharmacokinetics, drug response, the risk of side effects. And just some of the key tenets of the pharmacogenomics initiative for the Biobank. I think probably the most important one is that we're taking a preemptive strategy. And so what that means is genotyping occurs and results are filed in EPIC without any association to a participant's current or past medications. And that's very different than a lot of genetic testing for pharmacogenetics these days. Generally, it tends to be more of a reactive approach. If it tends to be more in line with the medical decision-making process or in response to a side effect occurring. But we see quite a few programs across the country and biobank programs like ours moving to this more preemptive strategy. And so we're really excited that we can offer this preemptive strategy to our biobank participants. As I mentioned at the top of the talk, the PGX return is more of a semi-automated return. And so after the sample is genotyped and the lab director signs off on the results, we ultimately take the results through a number of different steps that involved a translational informatics service, a results translation engine, and then a custom interface with EPIC. And I'm not going to get in all the details and the tech aspects of that, But ultimately, what that allows us to do is to take results through an IT infrastructure that ultimately files them as discrete data in the electronic health record in Epic, much like you would file a serum creatinine. And why is that important? Why am I making a big deal about that? Well, that's really important for us because our whole program is based off of notifying clinicians of drug-gene interactions at the point of prescribing through automated clinical decision support tools. And the way that we have to do that is that we trigger those tools off of those discrete data that are filed in the EHR. And so that's why kind of that mechanism of return is just critically important in this process. And so we build these automated clinical decision support tools specific to different drug-gene interactions. And as I mentioned before, participants receive their pharmacogenetic results at the time that they're returned to Epic. They receive them via My Health Connection. So here's a screenshot for those of you who aren't clinicians. This is a screenshot of what one of the clinical decision support tool alerts looks like in the electronic health record for a clinician. This is basically a patient that was ordered an antiplatelet drug. In this case, it's clopidogrel, and they had an at-risk pharmacogenetic test that was filed in Epic. And the clinician who prescribed this or ordered clopidogrel here, they didn't have to go back through the lab section to kind of look for the Biobank test result here. They just order clopidogrel and we program it to pop this alert up for them. And it pulls in the genetic information, the associated phenotype, what this means, and what they should do with the information. So really directly at the point of prescribing, giving them all the information they might need. So where are we at today? I know I said I spoke to this group a number of years ago. We prior to 2021, we had made a little bit of progress in terms of starting the PGX program. We had returned results for one gene. We had clinical decision support tools in practice for 10 drugs. We had returned results to just under 1,000 patients. We had a little over 100 drug gene interaction alerts in clinical practice. But it really was in 2022 and over the last year or so that things have really started to grow and explode. You can kind of see the growth in the program in a year's time frame. And here's where we're at today. As of right now, we are returning pharmacogenetic results for 7 genes. We have 30 drugs with pharmacogenetic CDS tools. There are over 18,000 participants who've received at least one pharmacogenetic result. We've returned over 55,000 pharmacogenetic results in Epic, and we've had close to 3,000 drug gene interaction alerts in practice. And this just shows the different types of medications that we have these CDS tools live across the UC Health system. And I'm not going to go into all the different meds. Really, the point of this slide, and this is really one of the tenets of the PGX program as well, is really these drugs cut across all therapeutic areas. We're talking psychiatry, cardiology, GI, infectious disease, neurology, cardiology, oncology, primary care, oncology, MS. So we really want to try to spread the benefit out to all types of different patients and not just focus on one therapeutic area here. So some considerations for return of PGX results, just some things that we think about. And these are just a few. I know this is we have a little bit of time to discuss this, but one thing that we place a lot of emphasis on is the strength of the evidence. And so we have a systematic drug gene pair prioritization process. We place a lot of importance in PharmD KB, which is kind of a national and international kind of clearinghouse for all things pharmacogenomics. We we put into clinical practice mostly drug gene pairs that have clinical practice guidelines, most of the time issued by the Clinical Pharmacogenetics Implementation Consortium, and or drug gene pairs that have pharmacogenetic information and FDA prescribing information. So we place a lot of importance on the strength of the evidence. We also want to make sure that we're maximizing benefit and minimizing harm to the extent possible. And so, as I mentioned before, we have those synchronous clinical decision support tools at the point of prescribing for clinicians. We also have asynchronous screening protocols in place for high-risk drug gene pairs or drug gene interactions. So let's say we decide to return pharmacogenetic results, a batch of pharmacogenetic results to the EHR tomorrow, and a patient is already on a high-risk drug gene pair. Our alerts fire synchronously when a prescriber goes to order or renew a drug. But what about people who are already on an active, or already on a drug? So for high-risk medications, we do an asynchronous screen. And for those participants, we will send an in-basket message notifying their clinician of that potential drug-gene interaction. We also do weekly monitoring of our CDS alerts, and we have weekly pharmacogenetic rounds with our medical director for the high-risk drug-gene interactions. And then lastly, some considerations for return of pharmacogenetic results. We want to think about increasing access and minimizing disparities. And just under a year ago, we moved to a new genotyping platform, which is known as the Global Diversity Array. And so that has more pharmacogenomic variants that are more representative of non-European populations. We also think about inclusion or future return of genes and variants relevant to populations of non-European descent. So while the biobank population is primarily of European descent, for example, we are returning results right now for CYP2C9 and a number of variants that are more prevalent in African or African American populations. And thinking about other genes in the future that might have frequencies, allele frequencies that are more common in non-European populations. We also are working on, we have live and continue to work on patient and clinician-friendly websites. And then we answer patient and clinician questions free of charge. We have CCPM clinical staff that does that. So with that, I'm going to turn it over to Curtis, who's going to talk more generally about some ethical frameworks and how they are applied or can be applied to biobank populations.
Thank you. I'm really honored to speak on behalf of the many bioethicists and LC members who thought about this over the years. I'm also cognizant of time. I see you guys have a lot of amazing questions in the chat, so I might go over this a little briefer than I intended just so you can ask your questions. I did want to take a moment to think about what are the unique ethical challenges of biobanks. If we could go to the next slide, Chris. One is that maybe you've already could tell that this is an unusual type of study. This is a research study that is really designed to change. We're going to learn more about our participants and have new sort of ideas of what the research is going to be. As Emily Todd just mentioned, like the new ACMG guidelines about return of results suggest that there's been previous guidelines. So those high impact variants that we think we should return to patients are constantly going to change. The benefit of our PGX variants are going to change. So just our technology is going to change. So it's really hard to consent someone to something that we know at the onset is going to look different a year or 2 years from now. This is also a research study that is really focused on making sure we have clinical benefit for patients. Some other things that I think we could devote a whole talk to is about privacy and whether that we can really promise any real privacy when it comes to genetic and genomic testing. And that the fact that these samples and data really have some monetary value. And so who gets to benefit from that monetary value? Is it the institution? Is it the subjects? There's been some really interesting study design, like maybe many of you have heard of George Church, who does a really great job in his research, but also getting in the news, who has a new study design where if your sample ends up generating some really interesting intellectual property, you as a research subject get a percentage of that. And so this is a hard study to think about. How are we going to consent patients? How are we going to design it? And I'm a little biased. I think this group has done an amazing job. And part of that is because at the onset of this study, people really thought deeply about the ethical issues, the regulatory challenges. And one of those people was Dr. Marilyn Coors, who retired recently. So as a bioethicist, I'm going to put her picture up. It wasn't just her, but really a lot of people thought deeply about this, about how we're going to deal with these changes over time from the onset. And I think that's one of the reasons that this particular biobank does such a good job. So next slide, please. Maybe many of you remember this press conference where in 2015, there was this big federal funding of precision medicine. Most of the headlines were the fact that it was a little over $200 million dedicated to precision medicine. Some programs that a lot of us have heard of, such as the All of Us program, sort of shifted as a result of that funding. But individuals who are really interested in ethics and regulatory work, like I am, we're interested in these two quotes. One, that precision medicine itself is going to have to change the way we think about our regulatory framework for research subjects. And in fact, they're not really research subjects, that they need to be more participants, active participants in this study. A two-way street as we learn more about individuals and more about our research goals, that we constantly have this new communication, and maybe that our old consent models are inadequate for this type of study design. My personal view is that we sort of haven't figured out what that needs to look like yet. And my guess is that the way we interact with our participants and think about their regulatory protections are going to change over as these studies progress. So we're mainly focused on the genetic issues on this talk, not on all the privacy issues or the intellectual property and value of those samples. And why do we talk so much about genetics? Well, like lots of other things in medicine, there can be some real uncertainty. Sometimes it's surprising to patients and subjects, maybe to some clinicians as well, that like what Emily said earlier, that a genetic variant does not always mean that you have a genetic disease. And half the audience thinks that's obviously true, and half are going to be a little surprised by that. That it really does impact a lot more people than the subject that you're talking about. It could have dramatic implications for many family members, and that makes it hard on a regulatory perspective when we think about what happens when we identify a genetic variant in a subject who unfortunately is deceased since we've had that sample. And is that still something that's really important for all of the rest of the family? And then a lot of these variants have a lot of impact on things far down the road. What a great example of that 32-year-old who has a BRCA1 variant, and just the fact that we are starting to talk about things that are not happening today, but tomorrow or 10 or 20 years from now. Next slide, Chris. So it's hard to give an ethics talk without showing some ethics principles, and everybody who's come to these every month like I do are used to seeing some idea of principalism. And I am representing these principles more from a clinical perspective than maybe we look at them from a research perspective. But I like this to remind myself that this is a balance. It is a balance between what patients choose, for example, what's on the consent form, and also what there is that risk-benefit ratio. And so that if we think about it that way, we might start to understand why this is two very different approaches to returning genetic results. On one hand, we have those high impact variants that could have some benefit, maybe not today, maybe in the future, maybe they don't, maybe that genetic variant does not cause a disease, but could also have some real harm in the insurance issues, so financial harms in sort of how we view ourselves or our family members. And when we have this sort of unsure of risk benefit, certainly we're really thinking a lot more about what does a patient really want? And that's why I'm guessing this group has really this in-depth second consent or second discussion of what a patient really wants. But we think about how different that is from the PGX results that Dr. Aquilante just talked about, where there really is very little, if any, harm to those PGX results. there really is some potential benefit, especially if you're on one of those medications, and it might have a very immediate benefit. And the group is really doing such a good job of only thinking about those PGX results that really have that great evidence. And so there's a very different shift here between risk benefit, and probably why we rely a little bit more on that initial consent form. So when we do think about, especially those high impact variants, Emily did such a wonderful job about talking about the fact that patients, even though they said they wanted genetic results, still have this right to not know those results, still need that information to think about, is this something that fits within my values of what I want for myself, for my medical care, for my family? And that is why so far we've leaned towards a more traditional consent model or discussion model before the Emily or the team of genetic counselors and providers release those high impact variants. That becomes really hard when we think about how we're going to scale. That was perfect, Chris. How we're going to scale these results. And a lot of people, a lot of really smart people have tried to think through, how are we going to scale consent to a large population? Because if someone has to sit with each patient for hours on end, we're really going to be only impacting a few lives. And so a lot of people have thought about this, and I'm just going to show a couple of slides about work that I've done. So sorry for that. I just realized at this moment that I didn't recognize our funders. So this was funded by NHGRI. So we did some consensus building around both ways that we could minimize the amount of time that someone needs consent, but what were those true, like, necessary things to discuss that we still think we supported individual decision-making, that we still thought that this was an ethical approach to consent. And we really did focus a lot on bioethicists with LC training, MD geneticists, and genetic counselors. And we came up to these 9, which was more than we were hoping for, things that we really still thought needed to be discussed every time we talk about these results. But this idea that they might need to be discussed really briefly, that most patients can understand these things quickly. And we've tried to, next slide, please. We've tried to think about how could we do this in what we call a very targeted or short consent model. And so to do that, we've done a whole lot of simulated consent for all kinds of conditions, from things that have really high impact cancer risks, or to things that have very low risk, increased risks. And for most of them, most clinicians said, you know what, this can be done relatively quickly, sometimes not face-to-face, often with some increased literature. And it really was exciting to us that most clinicians do feel that we can both support decision-making in an ethical way for patients, but also that it doesn't need 2 hours to discuss this, but that we can do this relatively quickly. And we're excited that this work is moving to sorts of some population genomic medicine approaches where we actually try real patients and not just simulated ones. Next slide. I see Jackie coming in to give us some time warnings there. I guess some quick take-home messages that I think often we also think about this as like it's autonomy or it's risk and benefit analysis, but there's a lot of things that we do to support decision-making. It isn't one or the other. It isn't a push-pull, that there's a lot of ways that we can support both our clinicians and patients. Next slide. I know I told you I was going to go fast. That my summary of what I think is most important is to think about these really big ethical virtues, which is we should probably be truthful with our patients. In other words, hey, this study's going to change. We're going to have new results that we might report to you, and we're going to keep you updated throughout. And to do those things we promise as our patients. And this is my last slide. So that really is my summary, that I think that this precision medicine, as we've talked about, is this new idea of research, this new partnership with patients. And part of that partnership, we have some obligations or responsibilities, and that is to continue to do the things we've promised, even though our research changes, even though our results changes, the big promises we make to them about how we're going to think about what's beneficial to them and tell them those results. And so in cognizance of time, I think I will end there and look forward to all of the great questions.
Thank you so much for their excellent presentation. We have 6 questions and I'm unable to prioritize, so I'm going to do it by first come, first serve. They're all excellent. As conditions are discovered and added, do you go back and reanalyze samples?
Dr. Crooks, are you on? Would you like to address that?
Who is
Emily,
that?
did you ask for Christy?
Yes.
Dr. Crooks?
Oh, she cannot unmute herself.
Yeah, can you answer the question, please?
Certainly. So we do intend to, as much as we have the bandwidth for, to go back and reanalyze our data and report out HIP variants that meet our criteria. We have pretty strict criteria on what we report out. And so as genes are added, we are likely not going to have a whole lot of additional work to do, but we do intend to keep up to date and go back and add in information as much as we're able.
Thank you. This is a personal favorite of questions of mine. Can participants refuse sharing of information with family? And the second part of the question, and can they refuse third-party requests for this information, like from insurance companies?
I'm happy to handle that. We can't require people to tell their families anything. We can encourage individuals to share information with their family. And that's a big part of the discussion that I have, is just, good stewardship of our families, and sharing of information is strongly encouraged, but it can't, of course, be required. And because of privacy laws, if anyone calls me and asks about their family member, there's absolutely no way I would ever share that information. As far as what people can do with their result, so when we provide an HIPV result, it is an ordered clinical test in their medical record. We have a medical director who orders these tests, and they are then resulted, and they are part of their medical record, and that result is then handled as is everything else in their medical record. So if there is a legitimate reason for their insurance company to have access, then they have access. The genetic results are not handled differently in their medical chart.
Thank you. Which platform do you use to generate the genetic data? And did you have any case where the clinical lab could not confirm the results from the original data? And if so, how was that handled?
I'll take that one. Thanks for letting me unmute.
Hey, perfect.
Yeah, so yes, the data that we use is research grade exome data that we receive through a partnership with a company called Regeneron. So we send them our samples, they perform exome sequencing, and we get the data back. Because those data are research grade, we can't return them directly to participants. And there have absolutely been situations where it looked like in the research data there was perhaps a variant that would be pathogenic that we were not able to clinically confirm. So since we're a clinical lab running validated clinical assays, our answer is the gold standard. Sometimes we'll try and troubleshoot if we think there's been something amiss, but otherwise, no, we take our answer as the gold standard answer.
Thank you. Are there any constraints to physical location? Someone signs up, their blood is in the data biobank, and they move out of the state.
So we are currently returning results, or these HIPV results. I can't speak to PGX, Chris, maybe you can. This is a verbal return of result, and we're putting the result into their medical record. So we're not providing clinical services, we're not providing consultation, we're not providing medicine, essentially. And so we can then provide a result to individuals in other states. It's a little harder than to help them find their resources, but we also can try to facilitate that as much as possible.
Yeah, and for PGX, the results would go through My Health Connection. So if they moved out of state to another health system, there's no kind of transfer of anything or no transfer of results.
And you would only try to use the most current phone number. There's no other search modality that you would use.
So when we're contacting individuals, we use their information that they have provided in Epic. So their phone numbers that are in Epic. And then additionally, we contact them through My Health Connection, which is attached to whatever email address they provided.
All right, this is from a person at the VA participating in the Million Veteran Program. And if you have data in 2 biobanks, CCPM and the Million Veteran Program, is there any communication of information, any attempt to coordinate?
Not generally as a rule, but in practice, what will happen is occasionally, and it's happened I think a couple of times so far, where we have a patient who has disclosed to Emily upon the return of their HIPV results that one patient said recently, oh, that's interesting, I already had a genetic test for this condition and it was completely negative. And in that case, what we do as a courtesy, so I as a lab director will contact that lab director if we can find a copy of the report, and we simply say, hey, there's a discrepancy between our 2 labs, to give them an opportunity to investigate. And the outcome of that investigation last time was that they were able to identify the same variant we did upon reanalysis of their data. So that's fairly common courtesy that lab directors offer each other. If the discrepancy were simply that we found something and they didn't, or they found something and we didn't, that would be more easily explained away by differences in technology and filtering. So probably there wouldn't be an investigation.
Final question, have you had to modify policies on treatment recs based on race, ethnicity, allele, frequency data?
We haven't had to modify policies. I think we have. I think the national consortium do a pretty good job of considering different race and ethnicities in clinical guidelines. I think if anything, what we've been doing is making sure that we are including some of those drugs and genes in our implementation protocols. Even if, our biobank is majority, people of European descent, making sure we include other drugs as well to spread out the benefits of the potential clinical benefits of the work.
Thank you all so much. This has been very informational. Join us again June 8th for Red Flag Laws in the Colorado Clinician with Dr. Chris Aquilante. And don't forget to register for the Colorado Healthcare Ethics Forum, Healthcare Professional Moral Distress, Burnout and Solutions, May 24th through the 25th. Thank you all very much.
Thank you.
Thank you.
Bye-bye.